Okay. Good evening, everybody. Myself, Dr. Ramdas Solanke. I'm working as a consultant neurologist at Orion City Care Hospital, Aurangabad. Thank you for allowing me to speak on this topic, which is very common in day-to-day practice. Slide. Okay. Before going to actual topic trigeminal neuralgia, let me speak on neuralgia. What is exactly meant by the term neuralgia? So this is the international classification for headache disorder, third edition, beta version 2013. In this, we have in part 1, 2, and 3. Part 1 are primary headaches. Part 2 is secondary headache, and third part is actual the where neuralgias are classified or put. That is painful cranial neuropathies and other facial pains. So basically, it is the part of headache. So ICSD-3 definition of neuralgia is it is the pain in the distribution of a single nerve or multiple nerve, which is presumed to be due to its dysfunction or its injury. And the most common types of neuralgia encountered in clinical practice are trigeminal neuralgia, glossopharyngeal neuralgia, intermediate neuralgia, which is the paroxysmal pain in the external auditory canal, and occipital neuralgia. The terms are self-explanatory. So, coming to today's main topic, trigeminal neuralgia. The IHCD definition of trigeminal neuralgia. This is the diagnostic criteria for trigeminal neuralgia, a disorder characterized by recurrent unilateral brief electric or shock-like pains, which is abrupt in onset and it is abrupt in termination. The pain should be limited to the one or more distribution of the trigeminal nerve, and it is triggered by non-painful stimuli also. Though the classic definition of trigeminal neuralgia is paroxysmal pain, in many conditions it is associated with the additional component of continuous pain in the same distribution. So this is a sub-classification of trigeminal neuralgia. Trigeminal neuralgia
क्या किया?
is classified into three main types. That is classic trigeminal neuralgia, secondary trigeminal neuralgia, which is also called a symptomatic trigeminal neuralgia, and idiopathic variety. So, classic trigeminal neuralgia. The term classic trigeminal neuralgia is reserved for the entity in which there is either neuroimaging evidence or post-surgical evidence of this microvascular loop causing compression over the trigeminal nerve. So the classic trigeminal neuralgia is due to vascular loop by definition, and this is secondary or symptomatic trigeminal neuralgia, which can be due to a multiple sclerosis, demyelinating plaque at the nerve root entry zone in the lateral pons, or which can be due to space occupying lesion, most commonly CP angle tumors, acoustic neuroma, or epidermoid cyst. And third variety, it is idiopathic trigeminal neuralgia. No, that is no, in that case, there is no vascular loop or there is no cause found on neuroimaging. There is no structural cause. Trigeminal neuralgia predominantly affect elderly people. The prevalence is zero point 0.7 per lakh. It is more common in women, that is 0.03 to 0.3%. Though the pain is mostly unilateral, it can be bilateral in some cases, especially when it is due to multiple sclerosis. The pain lasts for 10 seconds to 2 minutes and which is followed by a refractory period. That refractory period is variable from person to person. Attack frequency can be as low as 3 to 5 attacks per day to up to 50 attacks per day. Uh, Trigeminal neuralgia most commonly affects second or third division of the trigeminal nerve. It very rarely affects the first division or ophthalmic division. The patient may wince due to pain, hence it is called tic or tic dolorous. And the presence of these red flags points towards the symptomatic trigeminal neuralgia or secondary trigeminal neuralgia, like sensory deficit in one of the in the distribution of one of the division of the trigeminal nerve, bilateral involvement, and abnormal trigeminal reflexes like abnormal jaw jerk or absent this blink reflex that points towards the symptomatic or secondary causes. Coming to pathophysiology, the main pathophysiologic event is the demyelination. Demyelination at the primary sensory branches or primary afferents at the entry route, that is on the lateral part of the pons. So this demyelination is the basic cause for abnormal ectopic impulses, which generates the pain, and most of the time it is due to the abnormal vascular loop at the trigeminal nerve root entry zone. Neuroimaging, basically, trigeminal neuralgia is a clinical diagnosis. So we do neuroimaging only to classify whether it is idiopathic or classic or secondary, or to look into exact etiology of the trigeminal neuralgia. As I said earlier, the classic trigeminal neuralgia is a term reserved for the trigeminal neuralgia, which are due to abnormal vascular loop around the trigeminal nerve. These abnormal loops are mainly branches of basilar artery. That is, it can be anterior inferior cerebellar artery or superior cerebellar artery. So, in this, this is a MRI axial section T2 sequence, which is showing this is the pons. This is the lateral surface of the pons, and here we can see the exiting fifth nerve, trigeminal nerve, and this abnormal superior cerebellar artery, which is compressing the uh, trigeminal nerve. But the merely presence of the abnormal vascular loop doesn't cause the symptom of trigeminal neuralgia. Or if a patient is coming with trigeminal neuralgia and on neuroimaging we see abnormal vascular loop, we cannot attribute that pain due to that abnormal vascular loop unless there are signs of significant neurovascular compression. And these signs on neuroimaging are either displacement of the nerve, a distortion of the nerve, a flattening of the nerve, or atrophy of the nerve. Unless these signs are present on neuroimaging, we cannot label this as a classic trigeminal neuralgia. This was again a 25-year-old female patient who came with the same complaint, uh, left paroxysmal pain on left side of the face. uh, in this scan, we can see this is the again axial section T2 sequence. This is the pons. This is the lateral part of the pons. On right side, we can see a very well trigeminal nerve exiting from the lateral surface. But on left side, we cannot appreciate the nerve exactly. That is, exiting nerve is not visualized. Rather, there is abnormal mass seen on lateral surface of the pons. And on slight upper section, we can see the nerve exiting, which is compressed by that mass. So this was the case of secondary trigeminal neuralgia or symptomatic trigeminal neuralgia, and the etiology was CP angle tumor, epidermoid cyst. So these are the common differential diagnosis of the trigeminal neuralgia. Primary headache disorder like migraine, cluster headache, short lasting unilateral neuralgiform headache attacks, that is sometimes SUNA, hemifacial spasm, painful trigeminal neuropathies due to herpes zoster or post-herpetic neuralgia or post-traumatic dental conditions, sinusitis, salivary stones, and temporomandibular joint disorder, which are easily differentiated on clinical history and examination. Sorry. Coming to treatment part, treatment is either medical or surgical, and these are the American Academy of Neurology and European Federation for Neurologic Societies trigeminal neuralgia guideline treatment guideline. So carbamazepine and oxcarbazepine, these are the first line drug, and almost 70% of the patient respond to the medical management. Other medication or second line drugs are gabapentin, pregabalin, topiramate, lamotrigine, and baclofen. But most commonly used is carbamazepine, which has strongest evidence for pain relief, and oxcarbazepine, uh, which is better tolerated by the patient. Again, if the condition is not relieved by first line or first line medication, we add with the second line medication, and combination is necessary in most of the patient, and particularly for those who have secondary or symptomatic trigeminal neuralgia. And whenever we need to add this multiple medication, generally this is the indication, or this is the time when the role of the surgery is there. That means patient may need surgery in recent future. Before going to surgery, we can use the intermediate approach using onabotulinum toxin A, which is intermediate approach between medical management and surgical management, or we can use it for time buying. These are multiple surgical procedures will be discussed later. Uh, these are different medicines used in the management of trigeminal neuralgia. The first line are carbamazepine and oxcarbazepine. The side effects mainly are sedation, hyponatremia, and hepatotoxicity and myelosuppression in case of the carbamazepine. Though the drugs are well tolerated, this sedation and ataxia are common due to the sodium channel blocking nature of the drug, and hepatotoxicity and myelosuppression are quite rare. Oxcarbazepine is better tolerated than carbamazepine, but the incidence of hyponatremia is somewhat higher. It is up to 30%, 25 to 30% in case of oxcarbazepine, and it occurs in 10 to 15% in with carbamazepine. And the serious side effect is Steven-Johnson syndrome, though less encountered very infrequently, particularly in those persons who have HLA-B 15/2. Other medicines are gabapentin, pregabalin, topiramate, baclofen, and lamotrigine. These medicines are used as an add-on therapy with the one of the primary medicine, that is carbamazepine and oxcarbazepine. Most of them have sedation, fatigue, dizziness as a side effect. Uh, Weight gain, dry mouth, constipation are the other common side effects with almost all of them due to anticholinergic action, except for the topiramate, which causes anorexia. Most of the drug have weight gain as a side effect. But when started at low dose and titrated up, most of the drugs are uh, tolerated well by most of the patient. What is refractory trigeminal neuralgia? Actually, there is no common consensus on the definition of the refractory trigeminal neuralgia. But for most of the this research purpose, the practical definition used for the refractory trigeminal neuralgia is the trigeminal neuralgia which is not relieved by the conventional first line or second line therapy or combination of these. The causes of refractory trigeminal neuralgia, when it is due to secondary or symptomatic causes, inadequate dosing, and intractable adverse effects. Most of the times, when we practice, we see that the pain threshold is different for a different person. So many times it is too early to label them as a refractory trigeminal neuralgia because the pain is quite this non-tolerate, intolerable by most of the patients. So many times we prematurely label them as a refractory trigeminal neuralgia, and which requires the other surgical management or other procedures like radio frequency ablation and all that is discussed by madam. Thank you.
Thank you, sir. Thank you for the wonderful talk. I think sir has nicely elaborated regarding the classification, the pathophysiology, diagnostic approach, and various management, the medicines which can be used or preferred in patient with trigeminal neuralgia. But as sir has told that many times you may require the increasing doses or incremental doses of the carbamazepine or oxcarbazepine for the treatment, as well as there is a second line treatment or add-on therapies. But still the patient can have pain which might not be controlled only with the medications. So what to do next? What we should do? I think by far now we have understood what all drugs are available and what exactly causes and how the patient manifests. But if patient is not responding with the medication, what we should do? I think for that, I would like to invite Dr. Sunita Lavange madam to just elaborate and to tell us and to help us to know how further are there any options or how we should approach these patients further as far as the management of this what we call or what we commonly label as a refractory or non-responsive trigeminal neuralgia is concerned. So I first I'll request Dr. Jesharaj to introduce today's our esteemed guest and the next speaker, Dr. Sunita Lavange madam, and then we will have a talk from her.
Shall I start sharing my screen?
Just a minute, madam. I will just introduce you. As we all pain physicians know, no one is here who don't know the Sunita Lavange madam, who is very actively involved in the pain education as well as pain perpetuation in Maharashtra state. She is basically from Nagpur, and madam is director of the Ashwini Spine and Pain Relief Center. She is faculty at pain medicine in JNMC Savangi. Also, she is a consultant at various hospitals like Orange City Hospital, Alexis Hospital, and Vivek Hospitals. Madam is currently elected as a president-elect in national conference, which is held at Amritsar in 2023. Madam was president of ISSP Nagpur chapter in 2022-24. She was also had a experience of a vice president of ISSP National in 2019 and 20. She was organizing secretary of the ICRA Pain in 2019. Also, she was a president of ISC Nagpur City Branch in 2018 and 19. She is also a reviewer of a Journal of Indian Journal of Pain since 2015. She is the secretary of ISSP Nagpur Branch since 2014 to 18. She was also head of position of a GC member of ISSP national body and GC member of Indian Academy of Pain Medicine in 2016 to 19. She has attended various conferences, national conferences. She has delivered chaired sessions in the multiple conferences. Also presented national, international level poster in the ISP World Congress, which is supposed to be the one of the leading congress in the pain. She has special interest in the neuropathic pain and musculoskeletal pain and spine group. So with this all academic excellences, I would like to hand over my screen to Dr. Lavange madam. Kindly share
Thank
your
you.
thoughts and ideas.
Thank you. Thank you. Amol, share screen कशी करायची?
तुमच्या झूमला स्क्रीनवर क्लिक करा आणि खाली शेअर स्क्रीनचं ऑप्शन येऊन जाईल. जस्ट मूव युअर
आलं
कर्सर.
आलं.
या आणि
Share
जस्ट शेअर
screen
स्क्रीन
ला
क्लिक
करू
करा.
का हे?
हो हो.
Yes.
त्याला केलं त्याच्यानंतर मला डेस्कटॉप वर जायचंय तर कसं जाऊ?
तुमच्याकडे
शेअर स्क्रीन मध्ये समोर ऑप्शन असेल मॅडम, कोणती स्क्रीन शेअर करायची तुम्हाला?
मल्टिपल नाही, शेअर स्क्रीनच्या समोर ऑप्शन नाहीये म्हणूनच विचारते.
तुम्ही शेअर स्क्रीन क्लिक केलं ना मॅडम?
हा केलं.
तुम्हाला समोर ऑप्शन ओपन होईल मॅडम शेअर स्क्रीन केल्यावर.
शेअर स्क्रीन केल्यावर
हा
नाही होत शेअर.
इट विल आस्क सिलेक्ट विंडो.
नाही ना, ते नाही येत आहे म्हणूनच. ऍडव्हान्स शेअरिंग ऑप्शन्स, मल्टिपल पार्टिसिपेंट्स कॅन शेअर सायमल्टेनियसली. काय करू? शेअर
Can we share as a host your screen?
शेअर फॉर व्हिडिओ क्लिप, शेअर साऊंड आलाय पण दुसरं काही नाही आलं. शेअर फॉर ऑप्टिमाइज फॉर व्हिडिओ क्लिप. शेअर काय करू?
Amol sir.
हाँ बोलिए सर.
Yeah, ma'am. Before that, you have to open that presentation which you want to share.
अच्छा
Then
अच्छा,
you
wait. Okay, I'll open that first. This
Yes.
happens with me every time. I don't know.
Yeah, Vikas will be the better person to guide.
I have opened it. Yes.
to the share screen. Now come to the share screen, ma'am.
Right. Now I come to share screen. Share screen.
Click that share screen icon, ma'am.
हो, share screen icon ला केलं मी.
Now on that desktop, you will get your presentation.
I am unable to do so. That is why.
Yes.
प्रत्येक वेळेस मी तेच विचार प्रॉब्लेम.
Yes.
Okay.
Yes. Now it's fine.
Done? Yeah.
Yeah.
Okay.
Thank you.
Yes. Over to you, ma'am.
Yeah. Thank you so much. Thank you, Amol. Thank you, Jayshraj. And I really appreciate the initiative taken by you. And you're doing a great job. Heartiest congratulations to both of you. And you're going to do great and keep continuing. It will really help everyone. And from my side, best wishes. Any help required from my side, we are always there to help.
Actually, we are very fortunate to have you as a speaker in our first webinar.
Yes.
So actually, we are lucky in that part also. That in a single phone call, you have accepted my invitation.
Yeah. No. When it is from you people, I will never say no unless and until some dire emergency is there. Okay.
Yes. Thank you, ma'am.
So actually, the first topic, which was the first one, which was spoken by a great neuro physician from Aurangabad. Sir has already explained everything up to the medical management. Now comes what to do if the medical management is not, I will not say it's not failing, but there are some comorbidities or some side effects developing because of the drugs, or patient has become resistant to the drugs, but the pain still continues in spite of increasing the doses. So what to do then? Then comes the role of advanced pain management modalities. And then this trigeminal neuralgic pain has become refractory. So basically refractory trigeminal neuralgia means when the conservative line of management is not helping the patient to relieve his pain, and because of that, patient is developing side effects. So definition has already been told, and again I'll repeat just for everyone that it is also tic doulorex. We know why, because along with the continuous pain, patient gets muscle spasms. Why I'm telling about muscle spasms is then comes the role of Botox in such cases. So trigeminal neuralgic pain, especially the refractory one, is a chronic pain condition out where there will be electric shock-like pains, usually on the one side of the face, and it can involve one division or many a times two or all the three divisions also. There is an entity known as trigeminal neuropathic pain. So this has to be taken care of whenever we see a patient of trigeminal neuralgia. What happens out here in TMP is that this is a constant unilateral facial pain, okay, which is there along with trigeminal neuralgia also. But out here it is non-triggerable and unremitting. So there is no trigger point out there as it is in trigeminal neuralgia, because we all know in trigeminal neuralgia there are trigger zones, and simple touching, allodynia, eating, chewing, air, simple brushing of the teeth, it suddenly shoots the pain. But this is not in case of TMP. Out here, it is non-triggerable and unremitting. So whenever a patient of facial pain comes and if there is no trigger zone, then also you must think that this is a neuropathic pain which is related to the trigeminal nerve. Many a time it is post-traumatic trigeminal nerve pain also. And out here, what happens is there is some unintentional injury to the trigeminal system. So this can also result in trigeminal neuropathic pain. Apart from that, many a times inflammation, which is very, very common to cause this TNP, that is trigeminal neuropathic pain. And this can be due to post-herpetic neuralgia, sinus infection, dental pathologies like abscess, tumor. So out there, because of this inflammation, also this trigeminal neuropathic pain can be triggered. This usually occurs in paroxysms and it is spontaneous or evoked. It is constant, dull type of pain. So this is not electric shock like pain. This is dull pain, deep boring or burning in nature. Whereas the pain of trigeminal neuralgia is electric shock like shooting type of pain. We all know the incidence. The females, they have higher incidence of this, and the peak incidence is between 50 to 70%. I won't go in detail about this. The International Classification of Headache Disorders has classified trigeminal neuralgia as classic, secondary, or idiopathic. So it is the classic trigeminal neuralgia where there is vascular compression. Whereas in secondary, this is due to various tumors or underlying diseases. The most common is multiple sclerosis. And many times there is no cause known, so that is labeled as idiopathic trigeminal neuralgia. These are the various diagnostic criteria already explained very nicely by sir. We'll repeat it once more. These are the criteria which we should keep in mind whenever we see a patient of facial pain. I'm not saying trigeminal neuralgia, okay? So there has to be recurrent paroxysm of facial pain, which is unilateral, along the distribution of trigeminal nerve. Along with it, it should fulfill the criteria of B and C, not B or C, B and C. So what is B? The pain should last for a fraction of second to say about 2 minutes when it becomes chronic. It is severe or of severe intensity and electric shock like or shooting type of pain with very sharp quality. And what is C? There are some innocuous stimuli which precipitate the pain in the effective distribution. So A, B, C, when these three combine, this makes the us think that this may be a case of trigeminal neuralgia. So coming to the clinical practice algorithms, whenever a patient comes with intense paroxysmal unilateral facial pain, we have to first and foremost, the most important thing is history. History by history, we can definitely come to a conclusion and diagnosis that yes. So proper history taking is very, very important. We have to ask these following stepwise, where the pain is occurring, whether the patient is able to talk or not. How is he entering into your OPD? Where is his hand? You'll see his hand, he's just pressing the cheek and not talking at all. And the relatives are usually explaining everything. Whether the attacks are unilateral, where do they come, whether they are in the region of trigeminal nerve or not. And also very, very important is whether there are other unilateral autonomic symptoms. Autonomic symptoms are usually common when V1 is involved. MRI scan instead of CT is very, very important. Basically, when you are apart from the various basic investigations, you must go for new neuroimaging studies if you think that this is a case of trigeminal neuralgia. The reason is you have to classify and distinguish between the classic and secondary type of trigeminal neuralgia. So MRI brain is very, very important wherever you suspect trigeminal neuralgia, to distinguish between classic and secondary trigeminal neuralgia. Then comes the differential diagnosis. So whenever this patient comes, you have to ask about the dental pain, history of dental extraction, abscess, history of post-herpetic neuralgia, whether patient is having a mixed type of pain, say a TM joint syndrome or glossopharyngeal neuralgia, and other type of attacks which come usually with autonomic symptoms. So now comes the practice of how a patient you have diagnosed, and now it is the treatment aspect. Stepwise, the first thing is medical treatment. So medical treatment is started. Patient usually tolerates it in a very wonderful way if he comes at early stage. But if he's already on medications and he's getting insufficient pain relief, usually this happens when such patients come to us or they are referred by other neurophysicians or neurosurgeons. So here there is insufficient pain relief and the intolerable side effects are also there. So if the patient is a young patient, he's below 50 years of age, you should think of FBD. If a patient is elderly, you can go for radiofrequency of the trigeminal ganglia. This is the treatment, as Sir has already said. Carbamazepine is the drug of choice, but nowadays oxycarbamazepine, that is oxetol, is available with lesser side effects. Always remember that the trigeminal neuropathic pain has a psychological impact also. So along with the anticonvulsants, what you are giving, and also gabapentin, you have to add, and with that you add always one tricyclic antidepressant also. Baclofen is usually started in these patients, and this is the protocol how it is to be given. After every 3 days, you have to increase the dose till 20 milligrams. He can tolerate for 3 times a day, and then you can keep him on maintenance dose of 40 to 80. So my combination is carbamazepine when a patient first comes, along with baclofen. I start with 5 milligram and also one tricyclic antidepressant. When a patient of trigeminal neuropathic pain you encounter and you see that patient, then the line of treatment changes. So in those patients where there are no trigger zones there, you should start with tricyclic antidepressants, gabapentin, and topical lidocaine also can help them. The second line agents for these patients are tramadol and duloxetine, and the third line is lamotrigine. Let us now come to the interventional treatment options. So these are the various treatment options which come to your mind when a patient who has become intolerable to the medications and has developed severe side effects, and the dose is not sufficient enough to cause the less pain to him. During that time, what you can think of is, number one is microvascular decompression, gamma knife radiation therapy, percutaneous balloon microcompressions. So these all procedures 1, 2, 3 are usually done by the neurosurgeons. And but then when such patient comes to a pain physician, you can go for percutaneous neurolytic neurolysis of the ganglion by injecting glycerol or phenol or alcohol. Or else, if you have the facility of radiofrequency, you definitely, it has an upper hand above these neurolytic agents nowadays. So you can go for percutaneous radiofrequency ablation of the gastrian ganglion also. For the interventions, the indications are number one, trigeminal neuralgia, and secondary trigeminal neuralgia due to various disorders or systemic problems. But remember, these are the contraindications which you must keep in mind. That is why the basic investigations, your CBC count, your blood group, your whether BT-CT, everything has to be taken care of along with MRI whenever you post such patients for an intervention. So before going for the intervention, let us come to the anatomy of the trigeminal neural ganglion, where it is. So it is located in the cranium, in the Meckel's cave, and medially there is cavernous sinus, internal carotid artery, along with optic nerve. Superiorly there is temporal lobe, posteriorly brainstem, and anteriorly it gets divided into 3 branches, that is ophthalmic, maxillary, and mandibular. So this is the gastrian ganglion. You can see out here, this is the foramen oval from where it is coming and getting divided into 3 branches. So the one is ophthalmic, one is maxillary, and one is mandibular. When you, before seeing in the CM, if you have the skull, it will definitely help you in localizing and hence helping you in the CM or X-ray picture images whenever you do the procedure. So out here you can very nicely see the clivus out here and the foramen, bilateral foramen oval on both sides. When you see from front of the face, this is the place where your needle has to go. That is the midpoint of the inferior orbital margin. When you see at the submental view, this is how your needle has to go. So now first let's go to microvascular decompression. This I'll be telling you in short because we are not doing these things. So this is an open surgery and this involves relocating or removing the blood vessel or arteries which are compressing the trigeminal nerve. So what are the blood vessels? These are the most common one, which is usually compressing the trigeminal nerve. It is the superior cerebellar artery. So 80% of the patients in them, you will whenever you see the MRI, you will find out that the superior cerebellar artery is compressing the trigeminal nerve. The second most common is inferior cerebral artery, and many times the vertebral artery, and also sometimes petrosal vein, which lies near it. So what we do out here is what is done out here. This is an open surgery, so it involves high risks and side effects. So it has to be considered only when other things do not work. So out there, a Teflon soft cushion is kept between the artery and the nerve, and they both are separated. And since the cushion is out there, it separates, and that is why the pain, the trigger part goes off, and hence the pain is not there. So these Teflon implants, they are usually kept at the entry zone, and they are pushed ahead just parallel to the nerve. So what happens is the nerve and the artery, they both separate with that, and hence the pain factor is relieved. Out with this, usually patients get 75% relief of pain, and they claim that it is up to 5 years patients are totally pain-free. The second is gamma knife radiation, where computerized stereotactic method is used to concentrate these gamma radiations on trigeminal root entry zone. So out here, gamma knife means it is not a knife exactly. It is a very complex machine which uses cobalt 65. And out here, these high ionic radiations are concentrated precisely at the root of the trigeminal nerve, and it destroys the cell in that particular area. So because of that, the cells are destroyed, the pain factor is also taken care of. The advantages of gamma knife radiation are that it is non-invasive, it is painless, it is usually done in local anesthesia or sedation, and in a small period of time, say not more than 40 to 45 minutes. It is highly effective, but till now, again, the long-term benefits are yet to be established. So this is gamma knife radiation. Earlier, we spoke about the vascular compression. Now, what are the drugs which we commonly use when we proceed for balloon compression or neurolytic blocks? Blocks like peripheral blocks, which we give mandibular, maxillary, we use 1% lidocaine for infiltration and 0.25% bupivacaine or ropivacaine, which is usually combined with steroid like methylprednisolone or whatever which you use, tricot, etc., tricot or dexamethasone, which is optional. So if you are giving a diagnostic block, you can give it simple local anesthesia also, and if it is along with it, if you feel it is helping, you can go for therapeutic one also by combining steroid along with it. So these peripheral blocks also many a times take care of pain very nicely, and there is no need for going for the higher or the radio frequency techniques, which we can save for the later period. For balloon compression, we use 1% of lidocaine for infiltration, along with that, iohexol is also used. For neurolytic blocks, alcohol, phenol, or glycerol are used. You will see the dose, it is very, very less. Alcohol is hardly up to 1 ml, phenol 1 ml, and even glycerol 1 ml. And this you have to give in titrated doses whenever you inject it. So coming to the balloon compression, you can see out here, this is the inflated balloon, which is, and it is separating the artery from the nerve. So that is why this is the artery and this is the nerve. So the balloon is in between these two, and that is why the pain factor goes off, because it inflates and separates the artery from the nerve. So out here again, you use these are the equipments which you should have. The main thing out here is the 14 gauge 10 centimeter needle is used. Initially it is put, and from that you have to insert the Fogarty catheter, that is 4 French catheter, which has to be inserted through this 14 gauge 10 centimeter needle. After that, it is inflated with contrast, for you can keep it for 60 seconds or more, and then again deflate it. You have to watch for hypertension and bradycardia whenever you are doing such procedures, and these are all highly technical aspect has to be taken care of, and usually these procedures are done by few of the pain physicians also, and mainly the neurosurgeons. For peripheral nerve block, which we give, that is, you can give your maxillary mandibular blocks, you can give supraorbital, infraorbital blocks also if there is severe pain and a trigger zone out there. For that, you use for skin infiltration, you can use a 25 gauge needle, 5 ml syringe for local anesthesia, and your normal 22 gauge spinal needle for injection of local anesthetics. If you are using radio frequency, then you need radio frequency generator, the cable, your RF needle, usually with 5 or 2 mm RF tip. For radio, I'll be talking about the neurolytic blocks and radio frequency technique. So patient is laid supine. Usually it is a submental view in which patient's neck is extended and the C-arm is placed approximately 30 degree caudal and 30 degree oblique. So this is the submental view, and the entry zone is 3 centimeter lateral to the angle of mouth with finger inside the mouth. So you need not go deep inside and cause trauma. The needle has to be directed towards foramen oval. So how it will go? It will go by, if you direct it towards the pupil in AP view and midpoint of zygomatic arch in lateral view. So once your needle is in position, look at the ipsilateral pupil in AP, and laterally, if you see your needle, you will see it at the midpoint of zygomatic arch. So, and you have to direct the needle to an angle which is produced by clivus and petrous part of temporal bone. So this is the pituitary fossa, this is the anterior clinoid process, this is the posterior clinoid process, and this is the clivus. So clivus comes out here, and this is the petrous part of temporal bone. So this is the angle where your needle has to be to go. So this is foramen oval. So your needle is passing through the foramen oval out here. So this angle has to be maintained whenever you see the image, X-ray image in AP oblique as well as in lateral. If you are giving a neurolytic block, once the position of the needle is confirmed, always look for blood or CSF coming out. You can put dye also if you want to confirm the position, and then give around 0.5 ml of local anesthetic or neurolytic agent, which should be in titrated to doses of 0.2 ml. Not more than 1 ml should go at one time, and this has to go in small aliquots. If you are giving 50% of glycerol, the patient has to be in semi-sitting position with neck flexed, and he has to remain in that position for more than 60 minutes. So neurolytic solution, again, I repeat, should not exceed for more than 1 ml. And the 3 commonly used neurolytic drugs are alcohol, phenol, and glycerol. So most commonly alcohol is not used, but phenol is used because it is viscous, it spreads less, and it has more contact time. Coming to RF lesioning, as you all can see, and we all are practicing out. So one has to get well versed with the C-arm, with the machine. Here we usually use 10 centimeter or 15 centimeter depending or length of the RF cannula with 0.2 or 0.5 tip, which is non-insulated. So after sensory testing and motor testing, you have to start the lesioning. So always remember, never go above 75, 60, 65, 70 is well and good. Early, if you're starting at initial stage, go with 60, 65 and 70. Don't go above 70. And for ophthalmic division, if you are lesioning that branch, then your temperature should never be above 60 or 65. This is to avoid the corneal loss of corneal reflex. So this is the video. I think so you all can see the patient of trigeminal neuralgia having severe pain. I had taken her permission, so that is why I have not kept an eye band. You can see the position of C-arm. Monitoring very, very important. Procedure has to be done under all aseptic precautions. See the very nicely, you can see the foramen oval, the cannula in position. In the lateral view, you can see. In the AP view, you have seen it. See. Go for sensory stimulation. Motor stimulation at 2 Hertz. Many a times, if you're doing maxillary or mandibular, you'll get such twitches if you raise the temperature. First cycle was done at 65, second at 70. Always check the cannula position again in AP and lateral view. In this patient, I gave her 3 cycles at 65, 70, and 75. It was the maxillary division which was involved. This is post procedure before patient got discharged. Pain out there. So you can see such patients smiling after doing the procedure instantly before they go. So this trigeminal neuralgia is such a boon and rewarding procedure that the patients get very good relief. And this patient, I had done the procedure in 2021, and now it is 1.5 years. She's totally pain-free. Last week only she had come for just review casually. She had come. She's not taking any medicine. So it is more than 1.5 year that patient is not having any pain. And I really feel whenever I see her, I feel so great, and I feel really very good because she comes smiling. And I just remember her face when she came earlier, what agony she had. And can you imagine, she was suffering from this pain since last 6 to 7 years. So you can imagine that these patients, they keep on moving and they are given lot of medications, and in spite of that, they are not getting good relief. So such patients really need help of pain physician. But then always remember that all these procedures are not without complications. So there may be loss of corneal reflex, which is very high with radiofrequency, but less with glycerol and balloon compression. Then anesthesia dolorosa is also very common with radiofrequency. So in such patients, you need to give gabapentin, antidepressants, and you have to convince them, you have to tell them before only that you are going to suffer from these problems, and it will take time and it will go away. And patients agree because they have severe excruciation. There can be motor deficit, which is very high with balloon compression, but less with RF rhizotomy and least with glycerol. Retrobulbar hematoma is common if in infraorbital block is given, because many times the eyeball can come prop out and there will be severe exophthalmos also. So you have to take care of that. Diplopia sometimes common, and infection and meningitis, though very rare, one has to take care of. So this is the comparison between radiofrequency, glycerol, and Gasserian ganglion compression. So you can see there is high pain relief rate with radiofrequency with very low relapse rate. At least 1.5 to 2 years, for 2 years, patients are totally pain-free if procedure is done in a perfect manner. There is high degree of effectiveness but then sensory deficit is out there which has to be taken care of. This sensory deficit is very less with glycerol, but the high recurrence rate is there, and fibrosis develops if you give glycerol. So repetition of this will hamper if we go for radiofrequency. With Gasserian ganglion compression, there is slight sensory deficit, but again, there is moderate rate of recurrence and very high motor deficit. So these all things we have to take care of. And recently, botulinum toxin is injected because, as I said, patients have severe spasm also. So this Botox, it has an anti-nociceptive effect with transitory action over the predatory of trigeminal nerve. What it does, it inhibits the release of neurotransmitters, and it is believed to reduce peripheral and central sensitization. So nowadays, botulinum toxin is also used rampantly along with this if there are various trigger zones present, in spite of giving you the proper procedure. If you have given done proper procedure, or if you are given adequate medicines, but then if these spasms keep on occurring, you can go with Botox injections. Then there are various intranasal sprays and peripheral nerve blocks, as I said, can be practiced whenever you feel that this patient will get benefit of them. Now, recently, when I was, before presenting this, I was going through some references, and there in neurology journal only in April 2008, they have said that if one gives sphenopalatine block with in such patients using 3 ml of 2% lidocaine, these patients get very good relief, those who are suffering from trigeminal neuralgia. So one can try about this also if you are well versed with this, and if you don't have radiofrequency machine. So initially you can do, and then afterwards, if patient get, if the diagnostic block works, you can go for RF also. Then in a new, recently in 2020 Pain Physician Journal, they said that there is a triad out there. These patients, they not only the trigeminal neuralgia is causing, nerve is causing problem. Along with that, sometimes they have clinical signs of greater occipital nerve irritation. Also, they have pain in the pre-auricular region also, sometimes headache also, sometimes behind the ear also, post-auricular, the patients have severe pain radiating. So this triad includes ultrasound guided trigeminal nerve block. Along with that, if there are signs of greater occipital nerve irritation, you can go with ultrasound guided greater occipital nerve block, where you can use 1 ml of 1% lidocaine with 20 milligram of depometrol or any other steroid which you are using. And if your patient presents with features of superficial cervical plexus involvement, like pre-auricular pain or vast pain in the posterior region of occiput, so there and neck, you can go with intermediate cervical plexus block with a mixture of depometrol and 5 ml of 1% lidocaine. So this was a study, and it looks quite impressive. So those who are practicing ultrasound, you can definitely go for this triad. And they said that with this, around 74% of patients of in their study, they were totally pain-free for 74% of patients had total pain relief for 3 months. After that, it came down to 54%. So definitely this is something which we must try whenever a patient of trigeminal TN comes with these various and different type of features. So coming to the end, clinic, always remember that this is a condition which presents with unilateral facial pain. It is a sharp electric shock-like stabbing or lancinating pain, which is in the distribution of one or more divisions of trigeminal nerve. The majority of cases are due to, 80% cases are due to neurovascular compression. Though it is a clinical diagnosis, neuroimaging study is recommended in all patients to differentiate between classic and secondary trigeminal neuralgia. Never touch a patient or go for any intervention advanced before going for an MRI. First line treatment, we all know it is carbamazepine, and definitely for trigeminal neuralgia, which is of many a times misdiagnosed as toothache, and many a times they get a lot of tooths are extracted, root canal treatments are done, but then the pain still remains there. So awareness and an interprofessional approach is needed between the primary care physicians, pain specialists, dentists, neurologists, and neurosurgeons. So definitely we can take care and we can manage such difficult conditions if this interprofessional and multidisciplinary approach is followed by this team. So definitely this is a teamwork. Thank you so much.
Thank you, madam.
Thank you.
Yeah, wow. That was very nice, elaborative, yet very precise and to the point of, and there were so many things to digest, but yeah, everything was very useful, and it was very nice to listen it from you. So,
Thank
and
you.
yeah, audience has also shown interest and they have put some questions in the chat box also.
Shall I
So,
stop sharing? Shall I do stop sharing
yeah,
now?
ma'am, yeah, you can please stop your screen sharing. You can just close it.
Come on.
Yeah.
Yeah, it is there. Yes.
I have a question with Dr. Ramdas, sir.
Sir, your screen is very. I think Arvind sir is there, na?
Yeah. Myself.
Okay, sir. Okay, sir.
Thank
Go
you.
ahead. Anyways.
Ramdas, sir. Hello. Is Ramdas, sir, hearing me?
Yeah, he's there, but he has
Yes, sir.
muted
Yes, sir.
himself.
He
He's
has
there.
muted
Can you?
himself.
In your classification, you mention a typical trigeminal neuralgia with concomitant continuous pain.
Yeah.
The classical is sharp electric shooting type of pain.
Yeah.
That is typical neuropathic type of pain. But
Yeah.
what about this concomitant continuous pain? What is the character of that pain? Whether it is nociceptive type or neuropathic type?
Neuropathic type. That is
It is also
not
neuropathic type pain.
yeah, not lancerating typical jabs the patient described. It is not the same quality. This is neuropathic pain.
It is neuropathic pain.
Yeah.
Okay, sir. And my question to ma'am regarding in history, one important, not question, I can say it is a suggestion. Though she mentioned in her clinical pulse, then history, the character of pain is most important. Because there is some entities like persistent idiopathic facial pain, in which the involvement of trigeminal ganglion or nucleus may be there, but I think these patients respond better to this spinopalatine ganglion block, what we call in initial days a typical facial pain.
Typical facial pain, yeah.
Yeah. And I would like to ask ma'am, do you prefer alcohol still in trigeminal neuralgias?
No, I have not used alcohol. I have
No
not
one is.
used till now because I started pain practice and within 1 year I took my RF machine.
Yeah.
So
That's right.
And alcohol is
I got
highly
it.
spreadable.
Obviously.
It spreads very fast. So unwanted effects
It is alcohol should not be used.
should
Phenol
not
is
be
the drug of
used.
choice with
Yeah,
glycerol.
yeah.
So
Should.
many of my friends are using especially there where RF is not there or patient is not affording, or terminal cases of cancer out there you can use. But in
It's
healthy patients like trigeminal
it's
neuralgia,
okay
I
for
always
terminal cases where
yeah
you
we
don't
should
have
not.
any option.
Yeah, and if we
But
have
I don't
option
think that it
and
should be used in purely trigeminal patients.
yes, and this is an era where very legal matters are there, so be careful.
Yeah, and again you
Okay.
mentioned one condition, that is anesthesia dolorosa, or we can call this deafferentation pain. That is more common with the alcohol. Have you faced
Yes.
any case of trigeminal neuralgia with anesthesia dolorosa?
Anyone? With alcohol or with RF?
No. After MVD.
MVD?
Yeah.
Yeah, I had. Actually,
Yeah,
MVD was done by a neurosurgeon.
Yeah.
And patients he had patient again had that pain, and it was so intense along with different pain that he had to send the patient to me, and he requested for RF. So like it was a very difficult situation, like patient already had done that and patient didn't get any relief, and then they came out there. So first I tried some cocktail of drugs, and I'll tell you one more thing. I went for dry needling in that patient.
Great.
Okay.
Okay. So many a times the muscle spasm and this all is there, the muscles are stretched. So if that little pain out remains, after that you can go for ultrasound guided dry needling. And that is why I'm telling ultrasound guided, because you know the depth where your needle is ending, and you should know the anatomy of those muscles also. So that also patient had very good, he was happy, but not totally relieved. But ultimately,
No,
then I had to
let
go
me
for
know
RF.
the other people also who I don't know whether they know exactly what is anesthesia dolorosa.
Sir, sorry to interrupt you. There was one question on similar grounds to Madam actually by Dr. Radhika Marathe, and she's asking that how to deal with this deafferentation pain if it is post RF lesioning.
See, that is why I told you, you have to tell the patient that anesthesia dolorosa and deafferentation pain is going to come after that, but your pain will be relieved. Many a times they'll say that the whole, I cannot feel my cheek. There is heaviness. This patient, which I showed the video, this patient, when she came last time, she was unable to open her mouth. Okay. And when I asked her, why you are not opening your mouth? So she says, it is like that only till from the time you have done RF. So I said, you didn't come also for review. And that must be there because she was suffering from 6 to 7 years. She was not taking any tobacco or anything, betel nut. Because of that also the fibrosis can be there. But because of misuse and not using that part for 6 to 7 years, I could feel the thickness. All the muscles, they had become shortened. And then that point, instead of giving trigger point injection, and she didn't have any allodynia out there. So I did dry needling for that patient along the path. And I'll tell you, after keeping the needles for 20 minutes, when I took them out, the patient's opening had increased by 3 to 4 centimeters.
It is the same path we go for just gathering ganglion block.
Yeah, that was maxillary division. So maxillary division, what are the muscles? And you have to follow that whole path from the preauricular region.
And one more thing, madam, regarding this deafferentation or how to prevent it, not a foolproof thing, but nowadays many of them are advising to after listening you can inject either a particulate or a non-particulate steroid. So are you doing that, or are you in a favor to inject not a particulate but dexamethasone?
I don't do that, especially
You
when it is
mentioned
trigeminal. But only remember one thing, keep the temperature low.
Yeah.
So that can prevent. So instead of trying, ki chalo abhi 70 ho gaya, I'll do now on 75. Instead of that, be up to, don't go above 70. That will definitely reduce the deafferentation. I have done so many, and till now, means in this patient, I went up to 75, but many I don't go above 70 also. And these patients, they don't develop. Only this patient had that. She kept on telling me that there is heaviness in it.
There was a lot of debate. There was a lot of debate regarding the using conventional or pulse radio frequency.
Yes.
So where we should go for the pulse exactly, and where we should plan a conventional techniques to avoid deafferentation.
Pulse. For that, you should know the sensory supply and motor supply. So sensory supply to the face is by trigeminal, but the muscles of mastication, they are supplied, they have the motor supply from the trigeminal. So the mandibular nerve has both the conventional as well as, the sensory as well as motor aspect. So that is why even this was a maxillary in the video, you saw there were some twitches, but they came after 0.5. So that is why I didn't bother and I gave. I went up to 75. Maybe that was the reason that she has developed that heaviness in that part. So usually for mandibular, you should go with pulse therapy. But but with that, we don't get good relief with pulse. That is why we go with conventional. But remember one thing, don't go above 70 degrees.
60, what about ophthalmic division, ma'am?
Huh?
What about ophthalmic division?
Ophthalmic not above 60.
You will suggest conventional.
Possible,
you suggest conventional for ophthalmic division also?
60.
Conventional.
Yeah, you can go. It is sensory supplies there. That is no motor
but
supply.
corneal opacities can
corneal opacity or corneal reflex can go off, but with pulse, no effect comes, I'll tell you. So you can go.
I do have patients with pulse radio frequency in ophthalmic division. I have an excellent result for 3 years.
Yeah, they are doing great.
Yeah. Your patients having excellent pain relief for since last
they
3
are
years.
Doing good. They are doing good with pulse one. You can go with pulse 60 degree. You can do 2 or 3 cycles. So you go with pulse 2 and go with only one conventional. You can go, but don't go above 60.
Okay.
You can go with 2 cycles
for mandibular,
of pulse
you suggest
and 1 cycle
pulse.
of this.
For
or
mandibular,
you can repeat it afterwards if you feel that now see I have done pulse and my patient is good, well and good. If he comes again, then you can go for conventional explaining everything. But loss of corneal reflex, you all know it is so dangerous for patients.
It's not acceptable by the patients.
Many times instead of going for V1, I go with for supraorbital.
That is better option.
These are better.
That is better option.
So always think, and instead of going directly for RF, why not to go for first peripheral nerve blocks? Many times they do wonders and patients get totally, because there are many comorbidities also in these patients. those who come, usually they are 60 years, 70 years. So a lot of other problems also there.
Yeah.
So that is why you can go for the typical, what I said was by peripheral nerve blocks, and then you can definitely go for this, keep this reserved. What I say is RF of V1 branch. But if it is combination of V1 and V2, which is very rare, then you have to go.
Okay.
Actually, one question to Dr. Ramdas sir regarding the medical management. It is regarding the, of course, regarding the carbamazepine. The question is, we cannot exactly describe the duration, but suppose if the patient is prescribed carbamazepine, then how to monitor the patient if patient is consuming carbamazepine? And as you have said that oxcarbazepine is a better version. So when to prefer or when to shift on to oxcarbazepine? That is a question.
Actually, we use carbamazepine or oxcarbazepine. Never to shift. Well, it is not preferred or it is not advised to shift from carbamazepine to oxcarbazepine. It is individual's choice whether go for better pain management or better tolerability. It depends on patient also, patient profile also. And as far as monitoring is concerned, we monitor LFT and CBC because myelosuppression can be there. And many times, as Madam said, for a matter of medical legal concern, when we start patient on oxcarbazepine, many physicians advise them for HLA typing and to rule out that HLA B1502 because it is significantly associated
is
with
it mandatory to screen all the patients before starting oxcarbazepine? Is it so?
actually what teachers say when you are prescribing oxcarbazepine for any purpose for complex partial seizure or focal seizures or trigeminal neuralgia, you should go for that HLA typing. But many times it is not done. Actually, it is done hardly in any patient. And as far as monitoring is concerned, yeah, and as far as monitoring is concerned, we monitor CBC and LFT.
Okay, and for how long we can continue? That is also a question, but that is a practical question, of course.
Yeah,
but how long you can
started at low dose, that is 100 milligram twice a day, and it is titrated up slowly. And maintenance, maintenance comes when the patient has remission. We can wait for the remission up to a maximum dose of up to 1200 milligram per day. But it again depends on patient profile. Those who have very low pain threshold, in them physician is also compelled many times to go for add-on therapy like baclofen or any other gabapentin or pregabalin. But adequate trial of at least 2 months should be given.
Okay. Now actually, one very practical question from my side actually to suppose if you encounter such patients, suppose if you have a patient in your OPD, or suppose if there is a patient who is not responding to medication, what happens next to the patient? Because we all physicians, we are very eager to know what happens next. Suppose if they are not managed with this conservative modalities, what happens next to the patient? Is the patient subjected to surgery straight away?
No, actually, we do for add-on therapy, and if it is not allowed by even add-on therapy, then actually we suggest for surgery or any other procedure like RF.
Okay, you mean to say the second line, if the second line drugs are not working,
second
then,
line and combination.
Okay, I think that was the concluding statement of the madam's presentation, that we must need an interprofessional approach to deal with all such patients. And madam, actually, I want to tell both of you that this was the sole purpose of this today's webinar, that we want to include the other specialties also, and we also want to know what is their perspective and how they are dealing with such patients.
Whatever may be the etiology or underlying pathophysiology of the pain, the patient should be pain free, because that is what decides the quality of life. Actually, he is approaching us for the pain, not for the underlying disorder. It is actually us who find out what is the etiology. So pain, patient should be pain free. That freedom should be there.
Okay, and actually, as my question to madam is, ma'am, you have shown in the management of flow chart that if the patient is young, usually microvascular decompression is a preferred modality. But if suppose if we have diagnosed a patient with trigeminal neuralgia and on MRI there is no vascular loop, so what is the treatment of choice, or what is the treatment that you will prefer?
First is medications,
Okay,
conservative management.
okay,
Okay. And recently, what you said was similarly, day before yesterday, only one patient neurosurgeon had referred to me. MRI is
okay,
absolutely normal. Okay.
okay,
And he has started the treatment. Patient is 70 years old, not responding, having severe pain in mandibular region. So I had a chat with him. You see, there is no compression. So why to go for radio frequency? So what are you thinking? So he says, since the pain is out there, madam, nahi hai to fir kya? So what I am
I think we have lost connection from madam.
Ah,
Discharge,
yeah.
am I audible?
Yes, yes,
Yes, yes, you are audible.
Okay. Now
instead of
I
going
think,
to and
yeah.
doing radio frequency, you can go for diagnostic cum therapeutic nerve block. It can be mandibular. You can go directly. So these peripheral nerve blocks also help a lot. Why not to go for that if there is no compression? This is what I am planning.
Also, in such cases, can we go for balloon decompression? Because rather to do the destructive procedure, we can opt the balloon decompression. In
But
such
peripheral
idiopathic
nerve
scenario.
block, I am not doing a neurolysis. I am giving a diagnostic cum therapeutic
Okay,
nerve
okay,
block.
okay, okay, okay.
What we used to do when RF was not there, kya karte the? We directly go from here and give this. So why not to go hit the pterygoid plate and just go be below and put the drug and see if it is working or not. So since he's 70 years old, what I am thinking is maybe she'll get better with that instead of going for that. And for balloon decompression, see, we are not practicing. When a neurosurgeon is saying there is no need, she's 70-year-old, madam, you do RF only. So I said, I'll first go for a diagnostic cum therapeutic block. If patient becomes better, many times it helps. For months, patient do not have. So always keep this also in your mind whenever such patients come and there is no compression in the MRI. So instead of going for RF, we should try the peripheral blocks. So that
Breaking the pain cycle, breaking the pain cycle.
Yes. So that is why in the last slide, I have one line is there, peripheral nerve blocks. So go for that.
And the therapeutic block meaning local with steroid.
Yes, Radhika?
Therapeutic block meaning local with steroid.
Yeah. See, whenever there is some pain out there, severe pain, there is going to be some inflammation, right? And the patient is suffering from severe pain, definitely an anti-inflammatory effect will be there with the steroid. What we give is very less amount. It is not more than 40 milligrams, which is hardly 1 ml. So for peripheral nerve blocks, usually we give around 5 ml of the drug, which contains 4 ml of your local anesthetic and 1 ml of steroid. So it helps. And many a times, many of my patients, they became pain-free with these blocks also peripheral. And you can repeat them if they come after 6 months. When a patient 60, 70 plus years comes and the pain is not so severe, why to go directly for radiotherapy? We should keep that option last, especially when a person is referred from neurosurgeon. So we should go stepwise, what I feel, along with the drug combinations. This is my protocol, what I follow.
I think Dr. Kailash want to ask something.
Kailash Wagmare?
Yeah, he's
Yeah,
there.
hello, Kailash.
Dry needling.
Hi, Kailash.
हाय मैम
Hi. बोलो.
कुछ नहीं मैम अच्छा हुआ लेक्चर
Kailash,
You
if
can
you
start-
want to, Kailash, if you want to add
start the
something
video
from yours.
so we can see if the organizers allow. You can.
Yeah,
start.
yeah, sure, madam. Why not?
He's expert in dry needling, so
yeah, we need inputs from Kailash actually.
Yeah.
Very brief inputs. Yeah.
हेलो
Hi,
Am I audible?
Yeah, Kailash, you are there.
you are visible and audible both.
Kailash, you can have your own inputs, but in brief.
Actually, I am using non-invasive pulse RF treatments for trigeminal neuralgia.
Yes, yes.
Okay.
It's a non-invasive technique, and I find good results. And we follow these treatments with dry needling, and we cover all the muscles which are supplied by the mandibular division. That is both the pterygoids, medial and lateral pterygoids. Then along with it, the temporalis and muscle and the masseter muscle.
Masseter.
And along with it, I think C1, C2 divisions also are important to treat with. That is greater occipital and lesser occipital nerve. While doing pulse radio frequency non-invasively with SsPa, I also do take care that there is no tenderness at those areas, that is behind the ear, in those areas, because the referred pain there is around the ears, and which present as headaches
Headache.
along with it.
Yeah, there was this study
So,
which I told.
treating this,
Huh.
yeah. So, in all, with non-invasive RF also, I am getting the same results, ma'am.
Exactly. But when
And along with it, definitely there is gabapentin and muscle relaxants to be given to the patient.
So what I feel is
For medical line of management.
those where the MRI is normal, where there is no compression. So those patients we can go for such things. And that pain physician
yes,
journal 2020, if you get a chance, see it is available on the net, where they have done ultrasound guided occipital nerve block along with this mandibular or maxillary, whatever is involved. And they said that they got very good relief with it. And definitely what Dr. Kailash is saying about dry needling, I too follow, because whenever there is pain, there is neuromyofacial component. It is not the nerve. The muscles are always we try to neglect them. So muscles should be taken care of. So that is why this female who was unable to open her mouth, a single sitting of dry needling helped to open her mouth. Mouth opening was increased by 1.5 centimeter. So you can imagine, definitely it has a very big role, dry needling, especially because we have to take care of muscles also.
Dr. Kailash, thank you.
Thank
We
you.
always have some new and very innovative input from your side.
Thanks.
Thank you for joining. Yeah.
Yes.
I think we have covered almost all the details. Can we have 5 minutes, madam? With your permission, can we have more questions, 1 or 2?
Yeah, continue. It is already 9:26.
Yeah.
My talk was very long or what?
No, ma'am. It was not that much long. I think you have covered to the point and with very precise presentation.
And that was necessary, actually. That was necessary.
Yeah, because we all are doing interventions. So dry needling, again, I didn't put, but it will cover whole one lecture also. But definitely, we all should practice that also whenever the muscle part is there. So we should know little about dry needling also, everyone.
I'll ask and request from the I'll ask and request from the audience if anybody want to ask anything to either of the speakers. We can have your questions in next few minutes.
It was a great interaction. Everyone was asking questions, so they were listening, and I think so. I try to tell many new things.
So many new things we come to know, madam. Like what you are told, the dry needling regarding the greater occipital nerve, as well as the newer modalities with the ultrasound. There are so many new things which are coming, not only RF or say nucleolysis or isolysis. Apart from that, so many things we have to club. I think for that we have to evaluate the patient, what exactly the patient is complaining about, and not only concentrating only on the interventions.
Yes.
I think that was also the message from your side.
That was the main message. Why don't think always of RF, think of peripheral nerve blocks, think of Botox, think of dry needling, think of antidepressants. The role of antidepressant is very, very important in these patients. So these all things have to be taken care of along with the routine medications.
Okay, I think we don't have any more questions. So
Yeah.
I'll request our Honorable President, Dr. Arvind Rajgure sir, to adjust their light in the room so that everybody can see him, and then have a concluding statement and a vote of thanks. Arvind sir.
Thank you, Amal. First of all, I would like to congratulate you to arrange such a wonderful webinar.
Sir,
And
yeah.
having very experienced speaker from our branch, that is pain specialty, and Dr. Ramdas, he also gives very useful information regarding the trigeminal neuralgias and its different classifications and all these things. And of course, Madam have give a lot of clinical as well as practical aspects on the trigeminal neuralgia and different modalities. I would like to thank you both of them for giving that valuable time to us. Thank you, ma'am. Keep blessing with us.
And congratulations, SsP Aurangabad. You have done a
Thank you.
great thing.
Thank
Keep
you, ma'am.
continuing.
Thank
Yes,
you. Thank you, ma'am.
we
Thank
look
you very
forward
much.
for more of the webinars and interactive things. You can keep interesting cases also. That is
Sure,
also
sure.
there is a very good interaction if you have a very good chairperson out there, moderator. So you
Yeah,
can
yeah.
keep
Sure,
that.
ma'am. Sure, sure.
And,
We will try this.
Thank you so much.
Yes, madam, we will continue to do all such activities, and all the audience, including you, I want to tell you that we have decided that we are going to keep all these webinars on monthly basis, and we will be having it on the last Saturday of every month. So I'll take this opportunity to tell all the audience that we will be sharing you the flyers as well as the links, and please join and please involve yourself in such discussions, just to clarify ourselves regarding this upcoming modalities, or I will say the upcoming branch. And ma'am will be agree with me that everybody's contribution is very important, because now the Kailash came, everybody will have their own views, their own concepts with a scientific background regarding the topic which we are discussing. So thank you, madam, again. Thank you to join the webinar. Thank you, Ramdas sir, for sparing some time, and to, I think he is there. Yes, he is there.
Yeah.
Our President Rajgure sir to give me this permission right from the creating this branch up to this activity. Thank you, Dr. Jeshwaraj, for being there with us with the constant support, and thank you all the audience, all the reputed joiners. The Dr. Dhruv sir was there, Dr. Bhale sir was there, Chavan madam was also there, and all the other dignitaries and the delegates. Thank you. And here I'll conclude the activity. Thank you all. Thank you, everyone.
Thank you. Thank you. Thank you.
Good night, Amol. Good night,
Thank you.
Yashpal.
Good night, ma'am.
Good night.
Good night, Kailash.
Good night.
Good night. Bye bye,
Good
Kailash.
night. Have a great Sunday.
Bye, Kailash.
Okay.
Good night.
Good night.
Good night, everybody.
Bye.